Acute pericarditis. Etiology, pathophysiology, and pathology. There are many causes of acute pericarditis. 1. Acute idiopathic pericarditis. 2. Infectious, e.g. viral, TB, other bacteria, fungi. 3. Inflammatory, e.g. post-myocardial infarction or cardiotomy. Autoimmune rheumatic disorder. 4. Other, e.g. neoplastic, uremia, trauma, aortic dissection, hypothyroidism, irradiation. 5. Drugs, e.g. hydralazine. In the developed world, the cause of many cases is never established, idiopathic, but a viral cause is often suspected, Coxsackie virus B being most often incriminated. Tuberculosis is a major cause in the developing world. There is inflammation of the pericardium with infiltration of polymorphonuclear leukocytes, increased pericardial vascularity and deposition of fibrin. Inflammation can involve the superficial myocardium, and fibrinous adhesions may form between the pericardium and epicardium, and between the pericardium, adjacent sternum, and pleura. The visceral pleura may exude fluid, leading to pericardial effusion. Clinical presentation. Common. Chest pain, usually retrosternal or left precordile in location, radiating to the neck. The pain is aggravated by supine posture, coughing, deep inspiration and swallowing. It is eased by sitting up and leaning forward. It may be preceded by a few days of malaise. Fever. Uncommon. Dyspnoea. Symptoms of any underlying cause. Acute epigastric pain mimicking an acute abdomen. Anginal type pain. Cardiac tamponade. Physical signs. The patient may present with the following: pericardial friction rub, fever, atrial fibrillation, evidence of an underlying disease, signs associated with tamponade. Investigations. NB. The diagnosis of acute pericarditis is based on the following triad: typical chest pain, pericardial friction rub, classical ECG changes. ECG. The ECG may be normal. There is an initial, widespread, not V1 or AVR, upwardly concave ST elevation, followed by return of the ST segments to baseline and flattened T waves. T waves then become inverted before returning to normal over 1 week. It is necessary to distinguish these changes from those of acute myocardial infarction, in which ST elevation is convex and regional, R waves are lost, Q waves form and conduction abnormalities may develop. Fig 60. Acute pericarditis generally affects the ECG more extensively, with little in the way of the reciprocal changes seen with ST elevation myocardial infarction. Blood tests. Look for the following: elevated white cell count, erythrocyte sedimentation rate and C-reactive protein. Blood culture, atypical bacterial antibody and viral titers. Renal function to exclude uremia. Serial cardiac enzymes, which may show a modest rise, as directed by suspicion of underlying cause. Chest radiograph. This is often normal, but look for evidence of pericardial effusion, malignancy, tuberculosis, or aortic dissection. Echocardiography. Echocardiography is useful to exclude pericardial effusion or suspicion of aortic dissection. Differential diagnosis. Consider the following: acute coronary syndrome, aortic dissection, pulmonary embolism, musculoskeletal pain. Treatment. Emergency: pericardiocentesis if there is cardiac tamponade. Short term: admit if there is severe pain or large effusion, or for treatment of underlying condition. Treatment should include bed rest with oral NSAIDs given for symptomatic relief. Consider corticosteroids if there is severe pain not responding to NSAIDs after 48 hours. NB. In cases of acute pericarditis, stop any oral anticoagulants because of the risk of intrapericardial hemorrhage and tamponade. Long-term: if idiopathic relapsing pericarditis develops, corticosteroids or colchicine may be effective. Complications. Beware of the following: pericardial effusion, idiopathic relapsing pericarditis, cardiac tamponade, constrictive pericarditis. Prognosis. There is complete resolution within 3 months in 80% of patients, although 20% develop idiopathic relapsing pericarditis with chronic symptoms of pericardial inflammation. Cardiac tamponade may cause death if untreated, as may some of the precipitating conditions.